participants who have joined from various parts of India and this side of hemisphere. And good morning to our guest speakers for today. Welcome to this live webinar. I'm Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speakers, Dr. Jitma Abekun, Miss Grace, all discussants and participants to this virtual symposium on Erdheim-Chester disease, application of precision medicine in clinical management. Before we commence the proceedings, I would like to welcome and introduce the host and convener for this webinar under the aegis of Mumbai Hematology Group, Dr. Amit Khurana. Dr. Amit Khurana is a well-respected and humble senior hematologist and bone marrow transplant physician from Surat in Gujarat. I request Dr. Amit Khurana to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker of the day is Dr. Jitma B. Abekon from Mayo Clinic, Rochester, Minnesota, USA. And he's going to lecture us on Erdheim-Chester disease application of precision medicine in clinical management. And our second guest speaker is Ms. Grace Genu Whiting, Chief Executive Officer for ECDGA. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus, dedicated to life, and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan, and Team Zydus, Mr. Yash, Mr. Kalpesh, and the Team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speakers for the day, Dr. Jitma B. Abekon and Ms. Grace Genu Whiting, all our discussants who are themselves very eminent hematologists and medical oncologists, and you participants for sparing your Saturday evening, morning, and afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 12th of May 2024, we have Dr. Suprakash Sanyal speaking to us on inotuzumab and blinatumomab Indian scenario from 11 a.m. Indian Standard Time and Spanish time 7:30 a.m. And the second guest speaker we have with us is Dr. Joseph Maria Ribera, and he's going to speak to us on an update on management of adult ALL in 2024 from 11:30 a.m. to 12:15 p.m. Indian Standard Time. Let me introduce our discussants for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Abhishek Purohit from AIIMS Jodhpur, Dr. Akshay Mandloy from Agilus Diagnostics Mumbai Reference Lab, Mumbai, Dr. Amrit Kaur Keller from Kokilaben Dhirubhai Ambani Hospital, Mumbai, Dr. Anandraj Vedthi K from MGM MCRI Pondicherry, Dr. Ankur Ahuja from AFMC Pune, Dr. Aryan Jain from PGI Chandigarh, Dr. Chitra Madivale from PD Hinduja Hospital and Medical Research Center, Mumbai, Dr. Debalita Ray from MedGenome, Bangalore, Dr. Deepak MB from MSMC Narayan Health City, Bangalore, Dr. Gopinathan M from MGM Healthcare, Chennai, Dr. Neen Mya Thanda from North Okkalappa General Hospital, Myanmar, Dr. Hormaz Diyar Soli Sadri from Navsari, Dr. Jyoti Sauni from Gujarat Cancer and Research Institute, Ahmedabad, Dr. Kunal Chatani from Nagpur, Dr. Kunal Goyal from Actract, Mumbai, Dr. Mallikarjun Kalashetty from Manipal Hospital, Bangalore, Dr. Manu Vimla Chandra from University of Colombo, Sri Lanka, Dr. Meenakshi Suri from Jammu, Dr. Meenu Angi from Unipath Laboratory, Ahmedabad, Dr. Mohammad Taha Ali Khan from Hyderabad, Dr. Myat Malli Sway from Medley, Myanmar, Dr. Pujita Baireddy from Care Hospitals, Hyderabad, Dr. Prerna Chaudhary from Jaipur, Rajasthan, Dr. Prerna Chotmal from Bombay Hospital and Institute of Medical Research, Mumbai, Supanjali Oja from Rajendra Institute of Medical Sciences, Ranchi, Dr. Ramesh Balasubramanian from Meenakshi Mission Hospital, Tamil Nadu, Colonel Dr. S. Venkateshan from Armed Force Medical College, Pune, Dr. Satish Kumar A. from Manipal Hospital, Bangalore, Dr. Savitri Singh from Postgraduate Institute of Child Health, Noida, Dr. Shivani Joshi from Nashik Hematology Services and Mumbai Onco Care Center, Nashik, Dr. Subhangi Agale from Grant Medical College, Mumbai, Dr. Tushar Sehgal from AIMS, Delhi, Dr. Udyan Khachi from Vadodara, Dr. Yi Montan from North Okalapa General and Teaching Hospital, Yangon, Myanmar. Now it's time to introduce our guest speaker for the day. We have with us Dr. Jitma B. Abekon from Mayo Clinic, Rochester, Minnesota, USA. Dr. Jitma is an assistant professor of medicine and a senior associate consultant in the Division of Hematology at Mayo Clinic in Rochester, Minnesota. He received his MD from the University of Kansas School of Medicine, followed by a residency in internal medicine and a fellowship in hematology medical oncology at the Mayo Clinic Graduate School of Medicine. His research interests include rare blood disorders such as lymphomas, plasma cell disorders, and histiocytic and dendritic cell neoplasms. He currently serves as the co-chair of the Mayo Clinic Histiocytosis Working Group, and in addition to patient care, he is also involved in several translational research projects that relate to the integration of precision medicine into clinical practice. He has published several peer-reviewed scientific articles in hematological malignancies and was a recipient of numerous accolades, including the Mayo Brothers Distinguished Fellowship Award 2022, the Young Investigator Award from the American Society of Clinical Oncology, ASCO 2020, and the Conquer Cancer Foundation of ASCO Merit Award from the year 2018 to 2022. As a clinical investigator, he also aims to understand better and delineate disease biology, characteristics, and clinical outcomes of patients with these rare malignancies, focusing on identifying new treatment strategies and biomarkers. And today he's with us and is going to lecture us on Erdheim-Chester disease application of precision medicine in clinical management. Over to you, Dr. Jitma.
Thank you so much for the introduction, Dr. Amit Khurana. And can I share my screen? Is that?
Yes, sure.
1 minute. Can you see my screen as a full screen?
Perfect. Please go ahead.
Okay. All right. Should I start?
Yes.
Okay. Thank you, everyone, and good morning, good evening to you, with respect to where you belong in the world. So, and this is a great opportunity, and thank you for giving us this opportunity to present on these rare diseases. So the main theme, I just slightly changed my. Of course, we will discuss about precision medicine in Erdheim-Chester and other histiocytic malignancies. But I slightly changed the topic with Erdheim-Chester disease, and we will go through the basic discoveries, basic diagnosis, and then treatment strategies as well, because this is a fine opportunity for us to actually put these rare diseases forward and educate our colleagues and our patients so that it will be accurately diagnosed and the patients will be treated in a timely manner. So moving forward, I have no conflicts of interest. However, I will be discussing off-label drugs based on the US FDA approval. And this is the outline. The outline would be, first we will introduce the diseases, and then we will talk about the presentation of Erdheim-Chester disease. However, during this presentation, I will also touch about other histiocytic neoplasms, such as the cousins of Erdheim-Chester disease, such as Rosai-Dorfman disease, Langerhans histiocytosis, and other malignant histiocytosis. And then we will talk about the landscape, mutational landscape of these diseases, and we will learn from a real-life example how precision medicine being used in managing these patients, and definition of cure. And is there a cure? We will discuss about that and future directions. And also, I'm originally from Sri Lanka, so I know what things are available in that part of the region and what things are not. So please interrupt and ask questions when needed. And we will talk about next generation sequencing and all this as well, but also we do have other methods to manage patients nicely and accordingly based on the available resources. So I don't want to focus this presentation just to next generation sequencing platforms and high-tech medical practice, but I would like to cater this for every place in the world so that our patients will benefit. So the learning objectives would be to get to know about common presentations and classification of histiocytic neoplasms, especially ECD, Erdheim-Chester disease. Know when to include ECD or histiocytic neoplasms in the differential diagnosis, understand the common molecular pathways, and then understand the treatment landscape, and understand the importance of team-based practice. So common things are common. I am a hematologist and oncologist. Lung cancers, breast cancers, and the lymphomas are the most common compared to Erdheim-Chester disease and other rare histiocytic neoplasms. And also, we want to make sure that we communicate with our cardiologist, endocrinologist, dermatologist, and in managing these complex patients. And also, now these diseases are chronic diseases. We have continuous based treatment. So it is very important to highlight the survivorship for these patients, because our patients will live with this disease. And I usually tell my patients, like, it is unlikely our patients die from the disease, but usually we all are going to expire one day, so we will die with the disease. So it is important to uh, emphasize on the survivorship for our patients. So let's get started. Let's learn about what is the tissue of cell of origin. So I know that you might be able to see my cursor. So we know that the hematopoietic stem cell coming from the bone marrow, and the bone marrow has myeloid progenitors and lymphoid progenitors. And the histiocytic malignancies, for the most part, originate from the dendritic cell and macrophage. Macrophage, which originates from the monocyte. So in the myeloid cell, you have all these cells, and the lymphoid cells, you have BT and NK cells. And this is a disease in the macrophage and dendritic cell. So just for the basics, I tell my patients when I see them is that, tissue, so histio means tissue, cyte means cell. So this is a cancer of a tissue resident macrophage monocytes. So when the tissue resident macrophage monocytes goes to the liver, we call it a Kupffer cell. When it goes to the brain, we call it a oligodendrocyte. So we call it is in the skin, we call it a dendritic cell. We call the cells with different names where it belongs. But this is a cancer of the cell where it belongs in the tissue. So this is important to understand, because this implies that our patients can come with any of the symptoms and signs that can be originated from the given tissue. So if it is a cancer in the skin, that dendritic cells, so the skin originated signs and symptoms can come as rash and so forth, that we will discuss. So if it is in the CNS can signs and symptoms originating from the CNS can come. If it is in the kidney or perihilar or perirenal or retroperitoneal fibrosis, signs and symptoms associated with this. So my theme is, don't memorize any signs and symptoms. In histiocytic malignancies, any signs and symptoms, specific signs and symptoms can come in our patients depending on where the defects and which organs are involved, and any soft tissue, including hearts and great vessels, can be involved with respect to these cancers, because all this dendritic cell and macrophage can be seen in any soft tissue. So with respect to histiocytes, we have 5 different classifications recently. So L group, C group, R group, N group, and H group. So today, my main focus is in Erdheim-Chester disease, but of course, the L group carries the most common histiocytic neoplasms, Langerhans histiocytosis, and Erdheim-Chester disease. And R group is the next with respect to Rosai-Dorfman disease. And then the C group comes with xanthogranuloma, and M group comes with malignant histiocytes, and we will have dedicated lecture in the next week for malignant on the 18th on the malignant histiocytes. And then H group comes with hemophagocytic lymphohistiocytosis. So for this talk, I will mainly focus on the L group and some of the R and M group, but not on the H group, because hemophagocytic lymphohistiocytosis is a different talk by itself. So when it comes to histiocytic malignancies, recently it has been recognized as a cancer. But before that, it was recognized as a reactive disease. So because our patients comes with inflammation and inflammatory signs, if you check ESR-CRP for patients with Langerhans cell histiocytosis or Erdheim-Chester disease, indeed this will be elevated. So The way we identify clonal it is, as you all know, is that it comes from one single cell origin. So in histiocytosis, especially in Langerhans histiocytosis, the BRAF-V600E and MAP kinase pathway alterations identified in early 2000s, around 2010. And then in Erdheim-Chester disease, this was identified in 2012, 13, and 14. So because of that, now we know that LCH, ECD are cancers. These are indeed hematologic malignancies. It is important for our patients to know this because see where this actually anxiety provoking for our patients understand, but it is important for our patients to know because then they are equipped to to weather and stand with us for treatments, and then they to get the proper knowledge associated with the cancer diagnosis and associated survivorship. Rosa-Dorfman disease, for main part, it is a clonal origin, so it is a cancer, but there are patients that we cannot identify a mutation or anything, but yet the reactive inflammation is evident. So that is why it mostly a cancer, but some are reactive. When it comes to malignant histiocytosis, most are cancers, but when it comes to xanthogranulomas, it is still a debatable or a question whether this is a definitive clonal or reactive origin with respect to the disease findings. But Erdheim-Chester disease for this talk is indeed a cancer hematologic malignancy coming from a myeloid origin. It is indeed a rare disease. It has been recognized more in recent years because of the help that our ECD Global GA, or the Global Alliance, Histostatic Society, and NCCN guidelines, and all our great investigators have published. Because of those, the entire world has recognized these patients more in recent years, so that we believe that the prevalence will increase. However, for now, ECD is being diagnosed limited to case reports, about 3,000 case reports, and in RDD and LCH are also rare diseases. Then LCH 2 to 3 patients per thousand per year in United States as new diagnosis, and then annual incidence is about 2 to 3 in 1 million in the United States, and annual incidence of RDD ECD doesn't have a denominator. It is limited to about 3,000, 4,000 case reports. So disease manifestation wise, just a summary that histiocytic malignancies are cancers of monocytic macrophage dendritic cell origin. So it is a myeloid neoplasm, and tissue resident macrophage and monocyte resides in almost all soft tissues and bones. So if there is a cancer in macrophage monocytes of which resides in a specific tissue, that tissue function will be altered, thus manifest as clinical signs and symptoms. So if it is heart involved, arrhythmias can be involved, can be manifest as signs and symptoms. If it is great vessels, of course, hypoperfusion can be manifest. If it is CNS, hypophysitis. If it is skin, dermatitis, those things, bone pain, those things can be manifest. So nothing is pathognomonic. So that is why you have to have a big area with radar to diagnose these patients. When common things are common, when common things are not there, please entertain histiocytic neoplasms in your differential diagnosis. So average age of diagnosis of Erdheim-Chester disease is around 40s to 50s, so as RDD and LCH, Rosa-Dorfman disease, and Langerhans histiocytosis. ECD, there is a male predominance 1 to 1.5, RDD specifically female predominance, reverse of ECD 1.5 to 1, LCH, there is no sex predominant or predisposition. But important to understand that these patients will come to you in their best times in their lives, in their 30s, 40s, and 50s. So important to understand and diagnose these patients in a timely manner because they will benefit. They have the life to live, so they will benefit from timely treatment and monitoring. So then let's talk about what are our presenting signs and symptoms. This is the organ involvement of histiocytic malignancies. So this can be applied for ECD, LCH, and RDD as well. So specifically ECD, it is a bone confined disease. So I will show you the pathognomonic features of ECD. So mainly patients will come with bone pain. Then the soft tissue involvement, the kidney, para-aortic encasement, hypogonadism, lung, diabetes insipidus, maxillary mandibular joint involvement, pain, bone pain, CNS involvement, xanthelisma, great vessel heart involvement, retroorbital involvement, and pericardial disease. I don't want you to memorize any of this, but the take-home message is, you give me an organ, that organ can be involved with histiocytic malignancies because of the pathobiology or pathophysiology of the disease. Because the pathophysiology is, this is a deficit or problem with the tissue resident macrophage or monocyte. And macrophage of monocyte, which are tissue resident, can reside on any tissue. So that is why any tissue can be involved, which includes testes, ovaries, pituitary, the brain, the cerebellum, and so forth. So that is why broad differential diagnosis should be entertained when you see these patients. So these are the common presentation. The idea of this slide is to actually, with only different radiology or clinical findings or pathology is not enough to diagnose histiocytic malignancies. So it is unity of all three. So that is why we have to be best friends with our radiology colleagues, pathologists, and clinicians, because even not include hematology oncology, but also primary care internal medicine and all other subspecialties in medicine and surgery, because all these confined in unity makes the diagnosis, accurate diagnosis of Erdheim-Chester disease. So you can see the pathognomonic radiotrace uptake of distal femur and proximal tibia bilateral, and then xanthelismas. So xanthelisma like this is very common in hypercholesterolemia. You can see this, and other diseases too. But when it comes with this, and you see a bone scan like this, and then a CT scan showed hairy kidneys, periaortic encasement, pituitary abnormalities, or meningeal enhancement, then your ECD comes to your top of your differential diagnosis, at least should come. And then pathology will show CD68, factor 13A, BRAF V600. Dr. Aisha Ravindran maybe have done the talk or will do the talk on these pathologic findings as well. So she's a phenomenal pathologist at UAB, University of Alabama in Birmingham. At Birmingham, so she will delve through this in deep. But I will also talk a little bit about pathology in future slides. So these are the bone findings. What is important to know when William Chester and Jacob Erdheim describes this in 1930s, they find that this is a sclerotic lesion in the long bones. So these are the bone findings that you can see in Erdheim-Chester disease. So for patients with Erdheim-Chester disease, it's always a sclerotic lesion. However, for patients with Langerhans cell histiocytosis, it is a lytic lesion, similar to what you find in multiple myeloma. And in Rosai-Dorfman disease, it can be, mostly lytic, can be sclerotic as well. So that is why Erdheim-Chester is sclerotic, but when you entertain the cousins of the histiocytic malignancies, it can be lytic and sclerotic as well. So these are the pathognomonic findings of Erdheim-Chester disease. 95% of patients will carry these bone findings, but 5% of patients will not. So that is why I don't want this to be pathognomonic per se, but if you don't find it, but if your patients comes with other signs that such as xanthelisma or this type of hairy kidneys, periodic encasement, still ECD should be in your differential diagnosis. So these are the hairy kidneys. You can see from the CT scan. Of course, retroperitoneal fibrosis will have hairy kidneys, where these are much common compared to Erdheim-Chester disease. However, if you have Erdheim-Chester disease if you have this with other clinical manifestations such as the xanthelisma, hypophysitis, hypogonadism, and so forth, then you entertain a diagnosis of ECD. And CNS involvement is very common. 30% of patients with ECD can come with CNS involvement, and of those 20% can be primary CNS without any systemic manifestation. Even some patients will not have the classic bone findings. So these are the findings of the CNS. Pituitary can be involved, optic chiasm can be involved, tentorium can be involved, and also you can see the cerebellar lesions as well. So there is no significant one finding of CNS that I can appreciate. It can be in the spine, in the meninges, in the cauda equina, and anywhere. So common theme goes back. It is the cancer in the tissue resident macrophage monocyte, and this can be in anywhere in the meninges, in the brain parenchyma, in the skull, in the bone. So any disease can be involved. So these are the main great vessels. You can see aortic encasement, heart encasement. When it comes to the heart, the most common areas for the heart will be the right atrium. So if you have a right atrial encasement and also the great vessels such as the aorta, you should entertain the diagnosis of Erdheim-Chester disease. The great vessel encasement and the heart is not that much seen in other scenes of histiocytosis such as Rothschild-Hoffmann or LCH. Mainly CD is where we see this encasement of great vessels and the heart involvement, but can be seen in others, but mainly your differential diagnosis should entertain ECD. So these are the other cutaneous manifestations. You can see centralism. You can see these type of rashes. So as you all know, this rash, the maculopapular rash, that is seen in many different cases. In fact, some patients will have this without any involvement of the disease, acneiform rash. So, but if your patient has xanthelasma and this type of rash, plus other findings, diabetes insipidus, hypophysitis, great vessel involvement. That is where you should your radar should capture the differential diagnosis of histiocytic malignancies. So this is our own experience. Most patients present with bone pain. 16% of patients with diabetes insipidus, pericardial pleural effusion in 20% of patients, abdominal pain, visual changes are seen, and ataxia can be seen. So these things are nothing pathognomonic for any of the diseases in medical literature. Anything can present with this. However, the constellation of signs and symptoms are the most important to put in your brain, so that when you see these patients, that you will entertain a differential diagnosis of histiocytic malignancies. And you can have the mixes as it mentioned here. So the other things are the neurocognitive impairment. This is very important to understand, which actually, to be honest, we don't understand 100% the pathophysiology of this. So your patients or our patients will come in their 20s, 30s, 40s, and sometimes their disease is not involved in the brain. Their pituitary is fine, but their significant others will say like, hey, Mr. Smith was not the normal person that I used to see 3 months, 4 months ago. He forgets things now. He's a little angrier than before, or his sexual libido has decreased, and so forth. So that is what gives you a red flag. Say like, look, although you have a brain MRI completely normal, your CSF fluid is completely normal. If the patient has a histiocytic malignancy, they are much more prone to have invisible neurodegenerative component. So make sure that you be the best friends with your neurologist. Get your neurologist to see these patients and do the cognitive impairment analysis and treat accordingly. Sometimes treatment do help, but sometimes not. And we know sometimes the BRAF V600E altered cancers, which I will explain, have more cognitive impairment compared to BRAF V600E negative. However, despite BRAF V600E, about half of the patients, 40 to 50% of patients, will have some cognitive impairment that unless you focus on it, you can miss it. So that's why it is important to ask these questions from not from only the patients, from their significant others, from their loved ones, and get an idea about this. So let's go to the tissue diagnosis. So I will be very quick. ECD, LCH, and RDD will have a specific tissue diagnosis that you can go through. CD68163 are monocytic macrophage origin, so it will be positive in any monocyte and macrophage. CD1A is Langerine. Sorry, CD1A is not Langerine. CD1A is positive in Langerhans cell histiocytosis and negative in ECD and RDD. CD207 is Langerine, which is positive in LCH, and S100 can be positive in melanoma and small cell lung cancer and so forth too. But S100 is positive in all these diseases as well. Factor 13A is positive in ECD, Erdheim-Chester disease, compared to the rest. Two-tone giant cell and emperor polycis is positive in ECD and RDD respectively. And BRAF V600 is a genetic alteration which is positive in half of the patients with ECD and RDD, and about 3% of the patients, not 0, but 3% of patients with RDD. Not much. But MAP kinase pathway alterations can be seen in 1/3 of the patients. So when you look at this, just remember a few things, if you may, if you can, please, which is the factor 13A that can differentiate ECD from the LCH and RDD. Langerine and CD1A that can differentiate LCH from ECD and RDD. And those things will help you to understand. And emperor polycis, I will tell you what is emperor polycis, that can differentiate RDD from ECD and LCH. So this is a two-tone giant cell, not specific for ECD, Erdheim-Chester disease, but it is being seen in granulomatous inflammation, but mostly in ECD compared to LCH and RDD. Then this is the emperor polycis. So hemophagocytic lymphohistiocytosis is when the monocyte macrophage engulfs red blood cells. Emperor polycis is when monocyte macrophage engulfs neutrophils and monocytes. So you can see here some neutrophils, monocytes. So this is basically a monocyte macrophage engulfing their own cells such as monocytes and neutrophils. So this is what we call emperor polycis and can be seen in Rosai-Dorfman disease. So that is the pathology. When it comes to recommended tests, when you have the histiocytic malignancies in their differential diagnosis, you can do a CBC, electrolytes, of course, and liver function tests, kidney function, and LDH, like a dehydrogenase. So if possible, cell-free DNA for BRAF V600 can be done. But if you don't have this assay, don't worry. This is a very specific assay. If it is positive, that means you have the disease. If disease means you have BRAF V600, but not that much sensitive. That means if it is negative, it doesn't say that you don't have a BRAF V600 positive cancer. The beauty of this cell-free DNA is sometimes when it is involving the bone, if you have a biopsy, these biopsy specimens are difficult to undergo IHC staining or the next generation sequencing, because that is why it is a cell-free DNA in the peripheral blood is important and sometimes beneficial for our patients. So, and then imaging studies, the PET scan, of course, do it from head to vertex to toe, because don't go to the mid-thigh, because we need to know the distal bone involvement. MRI of the brain, sometimes you can focus on the pituitary, and cardiac MRI if you have signs and symptoms of heart involvement. The signs and symptoms could be, shortness of breath and echocardiogram abnormalities. And of course, if the patient says, "Oh, I'm very thirsty, I go to the restroom for all the time," and you want to entertain the decreased libido, menstrual irregularities, then you should order to assess for hypophysitis and gonadal and cortical function of the adrenal function. So this is a very important slide, I believe, because pattern recognition is very important. As hematologist, amyloidosis is not common at all. But if you see a heart failure, if you see proteinuria, neuropathy, and malabsorption, you have your differential diagnosis of light chain amyloidosis. And if you see anemia, thrombocytopenia, neurologic abnormalities, and renal failure, of course, we learn from our medical school exams that TTP is in your differential diagnosis. That is not common, but you are wired to make that in a differential diagnosis. If you have, similar to this, if you have bone sclerosis, diabetes insipidus, hairy kidneys, right ventricular involvement, please make ECD in your differential diagnosis. Similar to lytic bone lesions, cystic lung disease, papular rash, diabetes, LCH can be in your differential diagnosis. So pattern recognition is important. So let's now switch gears and understand the mutational landscape. So what is the MAP kinase pathway? So MAP kinase pathway is a very important pathway for healthy living of all cells in your body. So you have epidermal growth factor receptor. It actually recognizes the appropriate signal from the periphery and signals to RAS, RAF, MEK, ERK. These are oncogenes, but these are genes important for normal cell. And then appropriate cells sends a signal, say like, hey, you need to proliferate because we need the cells to grow. So this is normal cell. But what happens in histiocytic malignancies for about 70 to 80% of patients is that they do have a mutation in BRAF or MEK, the downstream pathways. And this actually makes a constitutive activation of this pathway without obeying for external stimuli. Now the cells doesn't care about appropriate external stimuli. The cells make the signal to the cells to proliferate inappropriately, and that gives the rise for clonal disease, which is a cancer. So that is why BRAF-V600E is seen about 50% of patients. MAP kinase pathway is seen in about 70 to 80% of patients in the absence of BRAF-V600E, and that is why these diseases are driven by this BRAF-V600E cancer mutations or MAP2K alterations, and that is why we can target this by the specific small molecule inhibitors. However, we know that this, although this is driving the cancer, I don't think this is the holy grail of this disease, because inhibiting this cannot cure the malignancy. It is actually can put the brakes, but if you get these drugs off, the cancer will come back. So this is the molecular landscape of most of the histiocytic malignancies, including LCH and ECD, not RDD, because in RDD we don't see this. Sorry about this. This should be BRAF V600D. That we don't see BRAF V600D in RDD, but ECD, about 50% of patients we will see BRAF V600D. The rest is being seen by MAP kinase pathway alterations, about remaining 40 to 45%. CSF1R, colony stimulating factor 1 receptor, is being seen about 1 to 2% of patients, and fusions of BRAF can be seen in about 6 to 7% to 8% of patients, and some are unknown. So let's meet a true patient. I got the permission of the patient to show her a picture here. This is actually a true name, and this patient is published in American Society of Hematology. If you Google, you can see her story, and this is a true story that I will present to you. And this patient is a 22-year-old female, actually coming with CNS involved ECD, and this patient was diagnosed in 2017 and comes with headaches and low intracranial pressure. And the patient went to outside facility, and then the patient did some MRIs. They couldn't diagnose anything significantly. They put a VP shunt to normalize the pressure, and then the patient was clinically fine, but some intermittent symptoms that comes, and until 2019, on May 2nd, the patient underwent patient had significant clinical symptoms, and the brain MRI was done and showed leptomeningeal enhancement and the CNS disease, as I mentioned to you during the last pictures. And I have some pictures of this specific patient. So you can see 2017 to 19, these patients indeed didn't have a diagnosis in the United States. So, and then in 2019, this patient underwent laminectomy and the biopsy. And the biopsy showed negative for CD1A, so this is not a Langerhans cell disease, and there is no IHC positive for BRAF-V600E. However, cyclin D factor 13A was positive, and the ECD was diagnosed. She did have slight involvement in the tibial and femoral lesions bilaterally. So then let's discuss about how do we treat these patients. Now we have the diagnosis of our patient as ECD, new diagnosis. Let's talk about how do we treat. So this is the treatment landscape of of ECD and other histocytic malignancies have been evolved throughout the last few years, specifically after the identification of BRAF-V600E and MAP kinase pathway alterations. However, not all patients need to be treated. So if you have a diagnosis of diffuse large B-cell lymphoma, if you have a diagnosis of lung cancer, the breast cancer, by definition, we need to treat the patient, no matter how localized the disease is. However, when it comes to histiocytic malignancies, you do not need to treat the patient if they don't have signs and symptoms of indication for treatment. That is the end organ failure, risk organ involvement such as liver, spleen, heart, bone marrow, CNS, diffuse disease, and constitution signs of malignancy such as the weight loss, night sweats, fevers, and chills and fatigue. So if you, in the absence of this, you don't want to treat, and in the presence of this, you need to treat. Please remember, the treatment of the disease should not be grievous than the endurance of the disease. So you should never harm the patient. Therefore, when deploy the treatment when only needed. So that is a very important paradigm in the disease because these are chronic diseases, incurable diseases. So all these treatments that we have in our armamentarium has side effects. So we should make sure that we deploy this when it is definitely needed. Do not unnecessarily want to deploy these treatments with significant side effect profile that can interfere with the patient's quality of life. So this is actually the treatment evolution of Erdheim-Chester disease. First diagnosis is in 1930 with that seminal paper. And from since 2004, there were some things that have I tried with respect to chemo. There was no significant trials or retrospective studies, but in 2004, vinblastine and MMF was there, and then everything until 2016 focused on inflammatory disease because it was an inflammatory condition. Interferon alpha, imitinib, anakinra, cladribine, all are inflammatory condition and managing inflammation. So then founding the ECD Global Alliance in 2008, and then BRAF-V600 ECD was first coined in 2012, and there became the targeted agents to target BRAF-V600 in 2013. And then 2014 ECD consensus guidelines was formed, and methotrexate and canakinumab was developed, and then sirolimus, the mTOR inhibition in 2015, and then finally recognition as a neoplastic disease in 2016, where the MAP kinase pathway was identified, and WHO categorized this as a cancer. And in 2016, cobimetinib was developed to target MAP2K, MAP kinase pathway. So COBI and vemurafenib are being validated by retrospective studies led by Dr. Eli Diamond and Memorial Sloan Kettering in the United States. And then, of course, it's casin, dabrafenib, trametinib, all are MEK inhibitors being used, and cytarabine in 2018. And we present the first patient that was used with the CSF1R inhibitor with pexidartinib in 2022. So this is the treatment algorithm that in clinical. So if you have a patient who merits treatment, you first ask if you have a clinical trial to be enrolled. If there is no clinical trial, you ask the question, is your patient with the confirmed diagnosis of histiocytic malignancy, Erdheim-Chester disease, LCH-ORDD, have a MAP kinase pathway alteration? If you have a MAP kinase pathway alteration, you ask question, is it BRAF-V600D? Is it non-BRAF-V600D? If it is BRAF-V600D, of course, you commence vemurafenib, but I will explain this. This is FDA approved in the United States, and cobimetinib, which is FDA approved in the United States. If there is no BRAF pathway alteration, you still can commence MAP kinase alteration because we know from Dr. Diamond's study that those patients who did not have MAP kinase pathway alteration, still about response rates were seen in about 20 to 30% of patients. If you don't have MAP kinase pathway alteration, you can then deploy immunotherapy, chemotherapy, anti-cytokine, and others, which I will explain in the future slides. So when it comes to treatments, of course, retrospective studies being seen in vemurafenib and cobimetinib with the response rates close to 90 to 100%. But there are mTOR inhibitors too, that is been in about 80% or so. And then interferon, cladribine, cytarabine, anakinra, infliximab, and methotrexate also been seen in about has been studied in retrospective studies. So the prospective studies have been vemurafenib and cobimetinib. Retrospective studies being was seen in about cytarabine, cladribine. So remember, vemurafenib, cobimetinib are continuous duration treatment. You put this patient as long as they live, they tolerate the treatment, or the disease is responding. So, but cladribine and cytarabine are fixed duration treatment. So after 4 or 5 treatments, you are done. Your patients can be observed without treatment. However, vemurafenib, cobimetinib are pills. Cladribine, cytarabine are IV infusion. So that is why it is important to educate our patients and make and informed decisions should be made. What is their preference? Do they want to come to an infusion center to get a treatment, or can they come want a treatment that takes the rest of their life, which is a pill? So because we know that if you discontinue this vemurafenib in about after 2 years or so, about 75% of patients will come back with the disease. However, that disease will still respond to when you reinitiate these small molecule inhibitors. The targeted therapy and associated adverse effects is significant. That initial phase 2 trial, they had to reduce, all patients reduce the dose of vemurafenib. I usually start at 480 milligrams of vemurafenib instead of 960. For cobimetinib, I start at 40 milligrams instead of 60 milligrams. That is approved in the melanoma space. But almost 60 to 70% of patients will have adverse effects from vemurafenib and cobimetinib, and these adverse effects come as rash, diarrhea, electrolyte imbalance, cardiac abnormalities, and also cytopenia. So these are the adverse effects when you compare the fixed duration compared to continuous duration. In the continuous duration, about 80 to 80% of patients will have joint pain and rash, fatigue, hair loss, diarrhea can be seen in about half of the patients. Neuropathy, nausea, edema can be seen in about 40 to 20 to 40% of patients. In fixed duration therapy, when it comes to cladribine, cytarabine are the fixed duration that comes every 28 days. You can do for 3 to 4 cycles, but there are adverse effects you can see here. And these are commonly used chemotherapeutic agents. So you have been using this, I'm sure, in myeloid malignancies and in the transplant setting. But remember, if the patient has this, it is a mostly fixed duration for 3, 4, 5 months. But if the patient has this, you need to manage this by putting them on antibiotic, doxycycline for rash, or azithromycin, or for ondansetron for nausea, and for antimotolytics for diarrhea throughout their time course that you treat these patients. So back to our patient. Of course, we do next generation sequencing because our treatment algorithm is equipped to for diagnosis, to make the treatments, and this all this I'm seeing obtain consent from our patient. So this is not personal medical information that without consent. So this patient has no somatic potential actionable mutation seen in their next generation sequencing. So we did not see this patient's MAP kinase pathway alteration or BRAF-V600E alteration. And then the patient, because of that, however, we treated the patient with MAP kinase pathway inhibitors. Why? Because we know that from our seminal clinical trials, about 1/3 of the patients may still benefit from MAP kinase alteration inhibition. So we treated the patient with cobimetinib. And then the patient, unfortunately, had significant adverse effects with cobimetinib, diarrhea, and we decreased the dosing, and the patient progressed. And then patient treated with interferon, patient progressed, and also she didn't respond well. And then 6 cycles of high dose methotrexate, did not respond well. And then radiographic and clinical progression was seen in 2020, significantly. And this is so at this point, the patient was in fact paraplegic, she couldn't tolerate lower extremity weakness was significant, and then also CNS involvement was there significantly, and the patient was having significant headache and nausea and vomiting. So this is the patient's involvement. Optic chiasm was involved, so bitemporal hemianopsia was seen. Pituitary, spine was involved, and this is her spine involvement. So then we came to the question. Now she has progressing. Let's repeat the biopsy, and the biopsy showed that nothing in the report of birth, but there is a variant of unknown significance, which is a CSF1R. So highlight is it is very important for you to actually look at the variant of unknown significance. These are rare malignancies. So when this is rare malignancies, it is actually our databases that we use with Cosmic and other places that in the internet is not very enriched with these diseases. So it is important to you look at the variant of unknown significance, and we notice a CSF1R 1R, and then this is the time frame of the patient. Now she is progressing, and this is what we have. We are asked the question, hey, what are we going to do? Are we going to do a treat with cladribine, cytarabine, or immune checkpoint inhibitors like pembrolizumab? Should we go to transplant, autologous stem cell transplant, or pexidartinib? We didn't use this because the patient was so sick for chemotherapy. Pembrolizumab is unlikely to give any significant merit in this because PD-L1 expression was not that high. So in malignant histiocytosis, when it comes to sarcoma, which we will address in next week, we have seen PD-L1 response, ICI response to high PD-L1 expression, but not in ECD. And she has a chemo refractory disease mostly because high dose methotrexate didn't work, and therefore autologous stem cell transplant is unlikely. So then we say either hospice or pexidartinib. Pexidartinib is a CSF1R inhibitor, FDA approved for tenosynovial giant cell tumor, which is a sarcoma-originated tumor in the sarcoma space, tenosynovial giant cell tumor. So then we decided to validate the CSF1R. Remember, do no harm. So first we need to make sure what we are treating. So we went to the lab, we validate the correlated for CSF1R inhibitor. So it is the ligand is interleukin 34, and CSF1R is involved in myeloid maturation, especially monocyte and macrophage. And tenosynovial giant cell tumor is driven by a CSF and collagen 6A3 translocation. And we tested the patient's alteration. So her specific alteration was tested. So she has a deletion of these amino acids and addition of glutamine, which is in a CAG coding frame of Q, so was added, and that actually was validated in silico at Mayo Clinic. So we noticed that when she has this type of alteration, this is a hydrophobic loop that inactivates the protein in their resting form. In the wild type, it actually shifts with her alteration that she has. So that actually validated to activate the patient's downstream pathway. And this is the CSF1R receptor. It can activate either MAP kinase or PI3AKT. In this patient setting, PI3AKT was the most active because she didn't respond to cobimetinib. And if you go to this paper, you can identify that the PI3AKT, phospho-AKT was so high compared to phospho-ERK. So suggesting that PI3AKT was more active than MAP kinase pathway. So inhibition of cobimetinib didn't work. So we decided to treat with pexidartinib. So we commenced on pexidartinib, and soon enough, the patient really regained lower extremity strength, tolerated oral diet. Her nausea, vomiting was subsided within 3 weeks of a time frame. Her hair became white because that was a side effect of actually pexidartinib, a known side effect. And this is her response. She achieved a complete response, and she is alive and well today. I just got the approval from the patient to present this from her mother today through a text message. So that is she's doing well. So that is what we are. I want to focus that you know of course, these are rare diseases, but please pay attention to the next generation sequencing if you can do it. But if there is no next generation sequencing, still I will address in future slides. Still, you can manage these patients appropriately by available resources and inflammatory medications, and also chemotherapy, which is cytarabine and tetrabenazine. So this is the team play is very important. You have to be best friends with your cardiologist, dermatologist, endocrinologist, pathologist, internist specifically, urologist, if they have retroperitoneal fibrosis and so forth, rheumatologist, and also radiologist. So then we talk about if there is a cure. So the definition of a cure is that the patient should not be on disease-specific treatment, and patient should not have cancer. That is the definition of the cure. So we know that if the vemurafenib and cobimetinib are continuous duration treatments, however, if we discontinue this treatment, the disease will come back within 6 months. We know that for a fact. But there are some patients, they might never come back. So it is not wrong for you. After 2 years, you can hold the treatment if the patient is willing to, if the patient wants to, there is side effects, and see the disease comes back on. If the disease doesn't come back, 25% of patients will do fine. If the disease comes back, you can re-challenge these patients, and then you can achieve the significant benefit. Of course, there is a fixed duration treatment too. Cladribine, cytarabine you can use at lower doses, 2.5 milligrams per square meter or so. And then you can see some publications say that after 2 to 3 years of follow-up, these patients might never develop disease. And so if there is a cure, there could be a cure with this fixed duration treatment. However, we don't have proper long-term follow-ups for these patients to actually tell you the exact definition of cure. As one could say in diffuse large B-cell lymphoma, 60% of patients will be cured. In Burkitt lymphoma, 80 to 90% of patients will be cured. In Hodgkin lymphoma, 75 to 80% of patients will be cured. But here, the data is still maturing, but there is a cure in the horizon, but yet it is uncertain. So this is again the evolution of ECD treatment landscape, which I have mentioned. And these are your future is bright. These are the side effects. Clinical trials that is being led. There are 2 clinical trials at Mayo Clinic. There is another clinical trial with a CSF1R inhibitor, which will just be open next month or so at Mayo Clinic. Too. So if there are patients that you can direct, they are willing to come. We are happy to entertain, but these are only at the United States. But we are looking at these for possible treatment options. So this is my approach. So if you have a patient with ECD, you first ask the patient, do you need treatment? If there is a treatment indication, then such as high risk specific organ involvement, and if it is spread out disease, you can initiate this treatment. But if it is localized disease, if it is only one skin rash, you can buy time by just radiating or local radiation or surgery. However, ECD is unlikely to respond significantly to prednisone or steroids, as you can see in lymphoma, but steroids could bridge some time for our patients for systemic disease if appropriate, but the response is minimal. If BRAF is 600E, ask the patient, do you need a continuous duration treatment or fixed duration treatment? I prefer continuous duration treatment because the response rate is about 90% compared to chemotherapy response at about 40%. If there is a MAP kinase pathway alteration and no BRAF pathway alteration, then again MAP kinase inhibitor. Cobimetinib, trametinib are options. Benimetinib. However, cobimetinib is not available, or cobimetinib has so much skin reaction, then you can change the treatment to trametinib. because sometimes interchanging within the same class actually will benefit. So I had a patient recently, significant grade 3 dermatitis, and switched to trametinib. Patient is tolerating the treatment fine. So, and then if you don't have this, that is fine. You still can give fixed duration treatment with chemotherapy. Cytarabine, cladribine, methotrexate, doxorubicin-based treatment, and so on. And if there is no alteration, if there is no target, if you have a CSF1R target, you can use CSF1R inhibition. Of course, you don't need to get pexidartinib. There are other CSF1R inhibitors like PAN, tyrosine kinase inhibitors that is available, that can be used, that has a target for CSF1R as well. And there is no fixed duration treatment, no target, then I would prefer a fixed duration treatment, because the response here is about 40 to 50%, and MAP kinase pathway alteration or inhibitors is about 20 to 30% in these patients, and these patients may have significant adverse effects with continuous duration treatment. So risk may outweigh the benefits of this region compared to here. So in summary, histiocytic neoplasms include ECD originates from a tissue-resident macrophage. Almost any organ can be involved. Driver mutations are abundant, but about 10% of patients will not have driver mutations. Pay close attention to mutations such as variant of unknown significance. And then targeting genetic alterations is important, can lead to durable responses, but make sure that you pay closest attention to adverse side effects, fertility preservation in young patients and so forth. So it is very important to maximize. You are actually maximize the quality of life with dignity for these patients, not a cure. So therefore, never harm the patient. Make sure you maximize the quality of life. And chemotherapy could sometimes be beneficial for some patients. In fact, in patients 60s to 70s, they sometimes can tolerate low dose of cladribine cytarabine, and these are fixed duration. And practicing team science is critical. And I want to put just a notice here that we have a histiocytic society meeting in your own home country at Goa, India. So please attend if possible, which we will have significant more education about histiocytic malignancies, including hemophagocytic lymphohistiocytosis and also histiocytic sarcoma. With that, I am open for any questions, and thank you for this opportunity.
Thank you, Dr. Jitma, for that wonderful and fantastic talk. It was worth listening to you. Please stay tuned with us, and I will introduce our second guest speaker. So we have our second guest speaker, Ms. Grace Genu Whiting. Ms. Grace Genu Whiting, JD, has been a Chief Executive Officer for Erdheim-Chester Disease Global Alliance, that is ECD-GA, since October 2023. ECD-GA is an independent non-profit organization dedicated to awareness, support, education, and research related to ECD. Her background is as an advocate for person and family-centered care with subject matter expertise in family caregiving, long-term care, health policy, aging, and disability. Previously, she also served as a CEO for the National Academy of Elder Law Attorneys, that is NAELA, as well as the President and CEO of the National Alliance for Caregiving, NAC, and as Secretariat for the International Alliance of Carer Organizations, that is ICO. Working with Global Genes and colleagues across the rare disease space, she led the first ever policy study of rare disease caregivers, capturing perspectives from 1,400 friends and family members of people living with rare diseases across 400 conditions. She is a frequent public speaker on topics related to caring for older adults and people with disabilities, including keynote addresses at the NIH Office of Rare Disease and for major media, including the New York Times, the Wall Street Journal, C-SPAN's Washington Journal, O Magazine, and Women's Health, and among others. Well, thank you so much. Over to you, ma'am. Please go ahead.
Thank you. And Thank you so much. And I'm just going to share my screen briefly. And I want to thank y'all too for giving me the chance to talk with you just about something that we're passionate about, as well as for the work that you do every day with patients um, and people who have this disease and this condition. So I just want to confirm, are you able to see the full screen of the slides?
No, not yet.
Let's see. Okay, give me one more second. Let's see. Okay. Let's see. And then how about now?
Perfect.
Okay, wonderful. Well, thank y'all again, especially I know some of you are joining in the evening. And we appreciate that. And I just want to talk about a couple of things from the patient perspective. So the first is just who we are as the ECD Global Alliance. I want to talk a little bit about that patient experience of Erdheim-Chester disease, and then why precision medicine matters from the perspective of a person who is living with the condition or the friends and family around them who care for them. And then I want to offer a couple solutions, ways that you can get involved and connect with others in the global community, such as Dr. Jithma and others who are working in this field. So who is the ECD Global Alliance? I'll go back for a second. You can see our amazing, incredible founder, Kathleen Brewer, who started the organization in 2008. She actually started this company because her husband died from ECD. And after he passed away, she got together with several in the community to create this alliance. We're essentially a global charitable nonprofit organization, sometimes called an NGO or non-governmental organization, that really works to bring together people who are living with ECD, their family and caregivers, medical professionals, and researchers. I mentioned, sort of how we were founded with the experience of the person living with Erdheim-Chester disease at the center of the organization. But we are also a research and learning network. So we just a couple of weeks ago, actually, I have a mug from the first Starbucks store. We were in Seattle, Washington, where Starbucks is from, but we were partnering with the Fred Hutch Cancer Center and the University of Washington School of Medicine, and had not only a meeting for our families and for people with ECD, but also for our researchers and our academics to share knowledge and ideas. So we have both sides of that community. And to that end, we have also invested more than 1.2 million US dollars in research on Erdheim-Chester disease. So this program, as as we talk about some of the milestones that we just heard about, and as our knowledge of the disease progresses, we have been able to also fund new and early career investigators. So helping to build a pipeline for people who are interested in studying ECD and other histiocytic disorders. So precision medicine, it's interesting. I worked in Washington, D.C., the capital of the U.S., for many years. And precision medicine is kind of a jazzy term that people were getting very excited about. And so I've pulled here both a definition from the National Institutes of Health, but also sort of the three aspects of precision medicine from an organization called the Personalized Medicine Coalition. And PMC works on helping people find precision medicine. It's really a sort of biomedical concept that takes into account the differences in a patient's genes and environments, and then adds on top of that sort of the social and behavioral determinants of health related to how we live our lives. On the right-hand side, this is from the Personalized Medicine Coalition, and this is what they see as the benefit to a person who is undergoing treatment to using precision medicine. I think the first is prevention. So you can think of, for example, the BRCA gene that can be an indication of breast cancer or ovarian cancer, that precision medicine in some cases allows us to better understand what our risk is of future disease diagnosis, and treatment, particularly finding more targeted treatment than something like a chemotherapy or sort of a blanket treatment that may or may not work based on a person's genetic background. Something I really felt reinforced in this morning's presentation is when it comes to that idea of precision medicine, ECD is very medically complex and it affects multiple different organ systems in the body. So what that means from the experience of someone who's living with it is that it's very difficult to get the right diagnosis, and that you could end up moving between different types of healthcare providers. And, while there are genetic components to ECD, not every case of ECD necessarily has the BRAF V600 mutation. So that complexity in diagnosing the multi-system disease makes it difficult sometimes to access precision medicine. And, to sort of come at it from a different way, if you think about as a person with ECD, you have all these different potential experiences. You could have everything from pain in your long bones and your legs, to heart issues, to reproductive health issues, to cognitive impairment. And so in most health systems, then we're bouncing from different organization to different organization. Dr. Medicne showed that slide of like the team of people you need. Well, from a patient perspective, that means that you need time and money to go and see all these different specialists, and some way for these specialists to communicate with each other. And even in the United States, where we have a robust system of medical health records that was incentivized by our government when the Affordable Care Act was passed, that's not seamless communication. I think the other element of that is we know that there are biases when you're working with patients that it takes a lot of training to sort of be aware of and overcome. And that may also make it very difficult either for someone to communicate what their experience and why it's different than just a normal disease of aging, and may make it difficult for some providers when you're in a rush and you've got so many things going on to even think or suspect that rare disease might be present. And that could be anything from language barriers, cultural barriers, religious barriers, racial and ethnic diversity, the impact of your environment, both, what, pollutants you might be exposed to, but also things like, do I have access to transportation? Am I living in a safe place? Do I have access to food and food security? And then that financial health and socioeconomic status. So that can all be barriers, not just to finding diagnosis, but to getting the right care, which again comes back to this question of sort of precision medicine. How do we make that possible for the people who would be good candidates? This is just a little bit more on that diagnostic odyssey. And this QR code in the bottom right, that's our consensus recommendations that the medical community has developed based on evidence and research to say this is how, we should evaluate, diagnose, and treat ECD. And of course, the science continues to advance. But I think, from a patient perspective, one of the challenges to precision medicine is that diagnostic odyssey. Again, comparing to the BRCA mutation, it's, the genetic component is there, but it is not a magic test that, immediately means, okay, this is ECD. ECD is complicated. It has a challenging and costly, time-intensive diagnostic odyssey. And so that's something to sort of keep in mind, as it is one of many tools in your toolbox that could be helpful. Thinking about that, if we think about what treatments are available, so, here, if you have the BRAF V600 mutation, whether positive or negative, that we know that there are treatments that work. But for others, so this is not even, so even if we know what the mutation is, there are still people that have ECD that don't have that mutation. So there's also a piece here about, when you don't have that genetic marker, is that contributing to medical uncertainty? And that's a question that's for smarter people than me to answer. But I think this idea of, as a person who's living with a life altering disease, a very intense cancer, it's frustrating not to get the right diagnosis. And then to get the diagnosis and know that there's treatments, but that treatment may not be the right treatment for you or for the person you care about. That can be a very challenging journey for someone to navigate. So it's something to keep in mind when you're working with people who may be in this condition, is they're trying to make informed decisions based on what's right for me. And you can have in ECD patients, young patients, teenagers. There's some evidence even in pediatrics, all the way up to end of life. So the way that somebody in their 30s might make decisions about the right treatment for them is going to be a lot different than the way you might make decisions at 70 or 80. So I think that those components also play into precision medicine, the need for the patient to voice what's important to them and what a good quality of life would look like. So how do you come at it? I think information is power. And one of the things I love about this community and the work of my colleague Kathy Brewer and the medical advisory board and others is they're very open in sharing the science with the people that they're caring for. Now, of course, some people may not take it home and read over it, but for many individuals, knowledge is power. It helps them know that people are working on this topic, and it also helps, I think, from a practice standpoint, that you don't have to start from scratch. And I think the consensus recommendations are a good place to start, precisely because you don't have to just start from nothing. There's been work already done, and we can continue to build on that. The other is just the power of global conversation. I mean, it's really amazing to think about, like, even right now, I mean, we're talking from across the world. I'm in, Louisiana, in the United States, down here on the Gulf of Mexico, basically, and y'all are on the other side of the world, and yet we're able to engage in conversation. And we have a care center network, which are physicians at institutions around the world who have treated or are planning to treat people who have ECD. So that's another place where, if you're encountering this and you're trying to figure out what's going on, that you can connect with other people who have real experience doing that. And that's the power of that network. And you can see in the slides, you can go to our website and see who those care center representatives are and how to contact them. Likewise, it does not cost anything for you to join our community and register to get more information. And as we put out new resources, new information, when we have events and webinars, this is a great way to connect with others and get a sense of what's happening in the field, where you can contribute, and to even potentially think about applying for research funding. I mentioned the 1.2 million US dollars in research funding. That's an opportunity for you, as you're doing clinical research, to think about continuing to grow our knowledge on this. So I will just say thank you so much. It's such an honor to be here, and just the passion that y'all have for taking care of others. I'm just in awe of what you do. So thank you for having me here and being a part of this conversation.
Thank you, Ms. Grace, for that wonderful insight. And thank you for joining us over here today, Saturday evening for us and morning for you. And I now request all of our discussants to please put the raise hand sign so that we can start our question answer session. So anybody wants to ask any question, any discussions over here? So in the meanwhile, Dr. Jitma, uh, if a patient has got, if a patient comes to you, sir, for example, 45 years male, I have a patient who comes to me with a retroperitoneal fibrosis. Our first impression is always to rule out IgG4 related disease. And if the patient does not, is the histopathology does not prove it is IgG4 related disease, and there are histiocytes on the biopsy, do we need to dig into the matter that this can be ECD in every case, such if you get any of this case like this?
Yeah, thank you. Very good question. So, retroperitoneal, as I mentioned, retroperitoneal fibrosis is actually relatively common in many other diseases, including IgG4 related disease or IgG4 disease. So, if IgG4 is ruled out with respect to pathology, and 60% of patients will have positive IgG4 and 40% will not in the peripheral blood. Yes, if it is ruled out, indeed, Erdheim-Chester disease should be in the differential diagnosis. However, IgG4 disease, so Erdheim-Chester disease is a cancer. So you can, I would recommend always submit to next generation sequencing if possible, or you can at least look at IHC for BRAF V600E antibody clone, so that you can get an idea about 50% of patients should have BRAF V600E positive. And if BRAF 600E negative, of course, next generation sequencing is the best way. If you don't have next generation sequencing available in areas, then what we could do is you can do other pathologic diagnosis, factor 13A, and also others, entertain the LCH and other areas too. And also PET scan would be very important. So for an example, this specific scenario happened to me last week. So the patient comes with retroperitoneal fibrosis, and then we actually did a biopsy. The biopsy showed the same thing that Dr. Amit Kumar that you mentioned. And then we did a PET scan. The PET scan showed very classic signs of tibial and femoral involvement, bilateral bone FDG disease. And that raised the diagnosis of ECD. So I treated the patient with cobimetin because BRAF V600 was negative by IHC, and the NGS was significantly, NG was submitted, but it will take about 1 month or so, and the patient is very symptomatic, meaning the ureters are being encased by the retroperitoneal fibrosis, and creatinine is increasing. So because of that, I decided to, and his cell-free DNA for BRAF V600 is negative. So because of that, most of the indication is on MAP kinase pathway alteration, other than not BRAF V600. So without waiting for 3 weeks, I commenced on cobimetinib, and he's doing fine right now. And I haven't assessed the disease response and waiting for the NGS. So yes, answering your question is yes, please entertain. If you have a retroperitoneal fibrosis and other diseases have been ruled out, ECD should be in your differential diagnosis.
And from the same note, if the patient has got histiocytosis, in such cases, if the cyclin D1 comes as negative, still we need to dig out the matter whether this can be seen.
Good question. So cyclin D1 has been positive in almost all diseases of ECD, and about very positive in about 56% in LCH and majority on RDD. And so cyclin D1 is a marker to show differentiate between clonal histiocytosis versus reactive histiocytosis, for that matter, because the hypothesis is that MAP kinase pathway activation actually triggers the cyclin D1 upregulation. Unlike in mantle cell lymphoma, if you have 11-14 translocation, you have a cyclin D1 amplification. But in here, similar to breast cancer and diffuse large B-cell lymphoma, 20% of patients will have cyclin D1 amplification. Similar to here, we think that it is a pathway activation, MAP kinase or PI3AKT increase the cyclin D1 amplification. If you don't see cyclin D1 amplification, that doesn't rule out ECD, to be honest, because these are small number of patients that we have identified and published. So still, it is not to say that ECD is not in your differential diagnosis. Despite cyclin D1, if you have PET findings, If you have patient clinical signs and symptoms presentation that I mentioned and NGS findings, you have a ECD diagnosis.
Thank you so much. Dr. Neema Thanda, your question. Dr. Thanda? You're muted, Dr. Thanda.
Thank you for your.
We cannot hear you, Dr. Thanda.
Okay, do you hear me?
Yes, now
Yeah.
we can hear you.
Do you hear me?
Yes, we can hear you now.
Oh, yeah. Okay. I'm very thankful for your comprehensive talk. We do not have access to NGS and no targeted therapy, but we have patients with similar scenario. So I like to, you have mentioned that in the study of Diamond et al., there is some response with the interferon and methotrexate and enacarina. So I like to know your experience or your center's experience regarding agents, because we are available these agents.
Yeah, thank you. That is a very, very important question. That's why I start this question. Agree and appreciate, and we hear loud and clear that this is not in the United States. We have access to NGS, but other part of the world we do not have. That doesn't mean that we cannot manage these patients well. So I actually treat these patients with cladribine, cytarabine, and interferon. Interferon, the problem is interferon actually has a very deep response. The patients who responds very deeply and sometimes very long durable response. But sometimes patients have difficult to tolerate interferon, like because of the adverse effects it carries through. But cytarabine, cladribine are low doses, have been well tolerated in patients, and it is a 28-day cycle treatment and 3 to 4 doses, 3 to 4 cycles that will be given the day 1, day 2, day 3 of the given cycle. So these patients do respond pretty well. About 50 to 60% of patients will respond, and some patients achieve complete response and they are durable. So if you don't have targeted therapy, that is the best way to go through the chemotherapeutic approach before going through the anti-inflammatory approach, and then go from there. And other things that really respond is actually not evident in the clinical trials is gemcitabine. Gemcitabine do tolerate well in patients and have good responses that we have seen. So meaning this is a chemo responsive disease, like whatever you do, cladribine, cytarabine, it's not a magic pill. There's a chemo responsive disease that you can indeed treat these patients if you don't have access to targeted agents. And in fact, targeted agents should not be used in all patients. I disagree with that. Some patients, though they have MAP kinase pathway alteration, it begs the question, right? Do you want to put a 40 or 30-year-old lady who has a skin rash with MAP kinase pathway alteration with cobimetinib, or throughout her life, which will give her diarrhea, which will give her side effects, which will give her problems with fertility, cytopenia. So that is why it is very important to have 3 things in mind. When to treat? Do you need treatment? Number 2, what does the patient really need? Is the patient okay to get some chemotherapy? Of course, chemotherapy has side effects too. Downstream myeloproliferative neoplasms can happen because of DNA damaging effects on some chemotherapies. So the and fertility issues has also, chemotherapy has side effects too. And then, does the patient needs a continuous duration versus fixed duration?
Another question, Dr. Thanda?
Thank you. And I have another question. Yes. Any response with the etoposide, like the HLH in ECT?
So yes, there are some reports showing the etoposide could have response for sure, the topoisomerase inhibitors, but there is no systemic studies that I could cite to say that you have a significant response in etoposide similar to HLH. So the biology of HLH is slightly different than ECD. So the HLH drives from a T cell mediated immunity. right? So when you come to HLH, hemophagocytic lymphohistiocytosis, if it is secondary in patients, it mainly comes with the T cell mediated cytokine immunity. So you target these immune cells, not the cancer cells, immune cells by T cell depleting agents, like etoposide and so forth. And also you sometimes patients ruxolitinib can work too, JAK-STAT pathway inhibitors. But the same approach may not be indicated in Erdheim-Chester disease because it is less inflammatory, more clonal, cancerous, more malignant. In HLH, it is more inflammatory, less malignant. So that is why it might be prudent to go through the targeted agents to attack the cancer compared to the inflammation, rather than other way that give you the T cell inflammation than attacking in HLH. But answering your question, yes, etoposide has some activity, but maybe cladribine, cytarabine may be better than etoposide in this setting.
Okay, thank you very much.
Thank you, Dr. Thanda. Dr. HP, name is HP. Your question, please.
Hello.
Yeah,
Hello. Yeah,
please.
am I audible, sir?
Yeah, you are audible.
Yeah, I'm Dr. Savitri. Sorry, my name is not coming. Technically a bit poor. So very good evening. Very nice presentation. Almost everything is covered. My question is, what is our experience of ECD in pediatric population?
Yeah, so thank you so much for the question. I'm not a pediatrician, so but ECD is mainly seen in so HLH is a pediatric disease mostly, primary, right? So we all know that. But ECD, LCH are mostly in adult or young adult is the main population. But there are some literature that Langerhans cell is also can be mainly seen in pediatric population. Sorry, ECD and RDD are mainly in the adult population. Langerhans cell is in pediatric patient population. What we know is that the recent literature has suggested both in pediatric LCH and ECD type lesions, the BRAF V600 is common. The MAP kinase pathways are common. So the recently clinical trials have devoted for these small molecule inhibitors to be used in that space as well. But the way we treat pediatric LCH is very different than currently compared to adult LCH, because pediatric LCH is very chemo heavy regimen, as you all know, than adult LCH, where we use less chemotherapy, more targeted agent if clinically appropriate. But answer the question, what is the experience in ECD? We don't have much experience in specific pediatric ECD, unlike pediatric LCH. But these are since these coming from the same kind of disease cell of origin. So therefore, I would anticipate with recent small literature that is coming, a very limited literature, that the BRAF MAP kinase pathway alteration should be very similar to adults in as compared to pediatric ECD as well. So the treatment algorithm should be mainly similar, but chemotherapy could be little better in patients as pediatric patients, as we all know from leukemia literature and LCH literature. And also it is very difficult for a kid to be on long-term MAP kinase pathway BRAF inhibitor treatment for years and years, because we don't know how that will affect the patient's development, to be a young adult. How do the neurologic development, we don't know.
Okay, sir, I have a small question, right? RDD or LCH, what we see in pediatric population, we have very classical features, and with only a handful of, diagnostic, tests, we can come to a conclusive diagnosis. Do you think how not to miss ECD in pediatric population? Could it be because of the so many chronic mimickers delaying diagnosis, or there is lack of awareness to think out of box about ECD as a possibility, like perinephric mass? We would always think of IgG4, which again is in case of adult. So I think if clinician also think out of box that this could also be a possibility, then only a pathologist will put other markers so that to rule out this possibility. Maybe more literature will come, more work will be done, and then we can think of that it also could be a possibility. Because what we see is RDD and LCH. Yeah.
Yeah, thank you. That is a very good question. So it is not only limited to pediatrics, it is limited to adults too. So Grace and myself recently, we wanted to spread the word, not in the hematology community, the
Clinician
so
as well.
exactly, primary care physicians are the front line practitioners, who
Yeah.
will first encounter these patients with skin diagnosis of rash, or problems with renal abnormal creatinine, problems with hypophysitis. So that is why. So last 2 weeks ago, I was present in this type of presentation in primary care internal medicine. So it is very important to get aware of colleagues of your own and also in other specialties too, to get this into a differential diagnosis. However, I want to tell you that common things are always common.
Yeah.
If the patient comes with a skin rash, ECD should not be in the first differential diagnosis. These common things are common. So we need to
Yeah.
respect that. However, when as you just mentioned appropriately, if you have ruled out IgG4, if you have ruled out other infectious etiologies or inflammatory
Yeah.
etiologies, and yet the patient still comes with signs and symptoms, then yes, we need to evaluate and get a differential diagnosis and entertain these histiocytic malignancies.
Yeah. Thank you, doctor, for all the clarification. Thank you.
Thank you. Dr. Manu, your question, please. Dr. Manu Vimla Chandra. You're muted, Dr. Manu. You're muted, Dr. Manu. Please unmute yourself.
Sorry, can you hear me?
Yes, we can hear.
Thank you, Dr. Abekwan, for that very nice talk and that very interesting case. My question is, when you are managing patients with rare diseases and you do NGS and you pick up these variants of uncertain significance, what is your approach towards acting on those mutations? Like, do you look at the specific mutation or the variant allele frequency? Which ones are just background sound and which ones really you think you should go behind trying to find whether it's actually causing the disease or affecting on the pathogenesis?
Yeah, thank you, Dr. Vimachal. That is a very good question, an important question. So, first of all, if you get a next generation sequencing result, you first look at what are the pathogenic alterations, right? If you have a BRAF, MAP kinase, or MAP2K, or anything, you act on that. If nothing there, you go to the variant of unknown significance. So in variant of unknown significance, when you sequence these slides in the tissue, the cancer cells in this tissue is about 5, 10%, 20% at the max. They are not like abundant tissue that have a lymph node of a diffuse large B-cell lymphoma, or for that matter. So if the variant allele frequency is about 60, 70, 80%, that should ring a bell saying that this might be a germline, not a somatic mutation. So it is very unlikely a CSF1R alteration or whatever the alteration is should be a variant allele frequency of 80%. Because that is unlikely with respect to somatic alteration in the tissue. So that is number one. You look at the variant allele frequency. If it is super high, then it begs the question: am I looking at like a germline, a mixed variant? So to answer that question, you need to either do a saliva buccal swab or a peripheral blood PBMC, sequence it, and see whether you find the same mutation. If you find 10, 20, 30% of variant of unknown frequency, unknown significance, VUSS, and then you ask the question, can we target? So the target, can we target, is a very good question. So the reason that we put a CSF1R there is that because we know CSF1R inhibitor it does exist in other diseases, like pexidartinib. So if you have other, for an example, ALK positive, ALK inhibitors, ALK positive histiocytosis, and also there are other pathway activators that mTOR, if you have a PI3 AKT pathway alteration, mTOR pathway inhibitors are there. So it is your colleagues and your team's knowledge of what exists in your armamentarium. And if that is true, then you have so many other very databases that you can go and validate if this VUSS is activating or non-activating, such as CleanVar, Cosmic, and so forth. And if you have, so at Mayo, we have a team, we have an in silico analysis, we have basic scientists that can recapitulate this and validate in a cell system and tell us in about a week time period, this is activating the mutation or not. If you have the capacity, that is best to do. But Dr. Vyamachandran, the medicine is a science and also an art. If you are patient in front of you desperately need treatment, and you have nothing to offer, and you have an ALK activating mutation that you think this could be activated, I think there is no harm in trying an ALK inhibitor and see. Let the disease speaks to itself, and then commence and repeat the imaging in about 2 to 3 months and do it. Of course, treatment of the disease should not be grievous than the endurance of the same. I do agree with that. If you think in your rational thoughts that you have a VUS, you have no you went to CleanVar, think that it might be activated but not sure, comments on it and treat the patient and see how the patients do.
Thank you very much. That was very helpful.
Thank you, Dr. Manu. So there are some questions from the chat box. Dr. Yimon Tent wants to know that if there is no bony involvement or any radiological features, then how would you differentiate from other histiocytic disease? And on the same note, he's also asked one more thing, that what is the easy way to approach in differentiating Erdheim-Chester disease from reactive histiocytosis?
From what?
Reactive ECD from reactive histiocytosis.
Okay, great question. So the first question is bone involvement. 95% of patients will have bone involvement, and it is sclerotic lesions. 5% to 10% of patients will not have it. In fact, my patient that I just showed you, Anya, she did not have bone involvement at the first diagnosis. Okay, remember, if you do a PET at the time of diagnosis, about 10 to 15% of patients may not have bone involvement, but this bone involvement can lag behind. It can come. So if you do a repeat PET in 3-4 months, the bone involvement can be seen. And please pay close attention to the head to toe PET and tibial and femur. More importantly, if you don't have bone involvement, that doesn't necessarily mean you don't have ECD, because bone is not pathognomonic alteration, although it is commonly seen. So if you have hairy kidneys, periaortic encasement type of a picture, or aortic involvement, atrial involvement, any infiltrative disease. So histiocytes are infiltrative, guys. Like these cells are infiltrating any of the given organ. So any infiltrative disease, plus you have factor 13A is positive, and also cyclin D, CD163, CD68 positive, perhaps IHC for BRAF V600E positive, it is ECD. You treat as ECD. However, but there are situations that we may not be very rare for now because of the molecular advances. There are situations pathologically it is very difficult. I do somehow, if you have a suspicion, I do next generation sequencing. If you have a MAP kinase pathway alteration, which is seen about 60 to 70% of patients, then and it is mutually exclusive BRAF V600 in MAP kinase pathway alteration, MAP2K alteration, then you treat as ECD as well, because you know that this pathway is active in about majority of patients, RAF MAP kinase pathway. So, and if that doesn't still work, then it begs the question: is this an inflammatory condition or not? However, in that setting, in my algorithm, as you said, if you really need to treat, you can try cladribine, cytarabine, and see how the response of the disease. And if that doesn't work, still you can try cobimetinib and see if the patient is responding. The second question is, how do you differentiate malignant histiocyte versus reactive histiocyte? I think our expert pathologist, Dr. Karen Rake and Aisha Ravindran, may have shed light on this. But we know from recent studies that cyclin D1 is a good marker to show this is malignant versus reactive. That is one thing. And also MAP kinase alteration. If you find a mutation, activated mutation pathway in this, that is suggestive of a clonal origin. So that is suggestive of a reactive clonal versus a reactive. You should never find a mutation, driver mutation in a reactive disease. Never. If you go to rheumatoid arthritis, if you sequence, you should never ever find a driver mutation. If it is a cancer. So that is why if you sequence a reactive histiocyte and you find a mutation, it is not reactive until proven.
Thank you. Another question from Dr. Pushpanjali Oja. What would be the diagnostic approach for monostotic lesion in ECD?
So monostotic meaning only one spot in the bone.
One spot.
So good question. That is actually not a rare encounter the clinical scenario. Sometimes we do encounter few things. ECD is a sclerotic, not lytic. LCH is lytic. So you do a bone scan, PET scan, and sometimes a bone MRI and identify the disease and biopsy. So the biopsy should show lesional malignant histiocytes, characteristic findings of IHCD markers and IHC markers of ECD. That is number one. Number two is that sequencing. Sequencing of a bone is very tricky because of the decalcifying process. Like when you decalcify this, the next generation sequencing sometimes fail. So because of that, in these patients, that is where cell-free DNA for BRAF V600 is very one of the things, because if we cannot sequence the lesion, there is a good specificity if it is positive for BRAF V600. If it is negative, then it is unfortunately difficult diagnosis. But IHC for BRAF V600 should work in that setting if positive. How to manage? First, always ask if this patient needs treatment. If needed, that means bone pain, decreased quality of life, I would first go with radiation. Sometimes radiation do help and go through. There is no reason for you to expose these patients to lifelong or 3-4 years of pill with significant side effects if they have only one side of disease. Another thing is do nothing. If the patient is an incidental finding and if the patient is fine, just do nothing. Sometimes, which is very important, in LCH, bone-involved LCH, actually bisphosphonates do work. There is a response rate of 60% with bisphosphonates. And also for bone-involved LCH, that's published. And also, bone pain is significantly decreased in these patients and increased quality of life, as you can see with bisphosphonates with other diseases in multiple myeloma, metastatic breast cancer, and prostate cancer. You commence bisphosphonate too. If there is a prognostic benefit, I don't know, as one could see in other disease types, but bisphosphonates do work for symptomatic management and actually disease control.
Thank you so much. Another question has been asked regarding the right atrial mass. So can Erdheim-Chester disease get present with the right atrial mass? One of the
Yes.
patients has been diagnosed as sarcoidosis and it was full of histiocytes. So whether this atrial mass can be the presentation in case of Erdheim-Chester disease?
Yes, definitely. So if you go to Rima Taufik's abstract and ASH, she actually in 2023, she actually put forward our experience, REEMA, Taufik TAWFIQ, that our experience. Sometimes the presenting signs would be right atrial mass, and right atrium is one of the most common places to be. In that setting, biopsy is necessary, but just a right atrial mass is very unlikely to be seen. They usually have the periaortic encasement, great vessel encasement that could be biopsied. But if not, right atrial mass should be biopsied, because as you just mentioned, amyloidosis can present too, and you need to do a fat pad aspirate and biopsy. And in these patients, definitely you need to do cardiac MRI to ascertain the disease entity, and then biopsy, do the normal testing, IHC evaluation, next generation sequencing. And if that, with the diagnosis, if patients can have only cardiac involved or great vessel involved Erdheim-Chester disease without bone involvement. For these patients, we recommend treatment rather than observation. And recommended treatment usually actually majority of patients with cardiac involved disease will have a MAP kinase pathway alteration in our experience. So we target the respective mutation either with BRAF inhibitors or MEK inhibitors. And they do respond, and we see that the cardiac function increase, the things decrease, the cardiac mass decrease, and so on.
Thank you. Another question is regarding the approach to a patient who is coming with neuropathy with ECD. So can just a neuropathy be the only manifestation of ECD? And if so, how to
Go ahead.
And if so, how to approach with this case? The
Yeah,
only
yeah.
neuropathy.
So involvement from macroglobulinemia with IgM evident transpacific lymphoma, multiple myeloma, neuropathy is common, because in Waldenstrom's, the IgM deposits in the neuron, in peripheral neurons and show the neuron. But here, Erdheim-Chester disease, you don't have a monoclonal marker or anything like that. The patients who develop neuropathy could be due to encasement of the disease. For an example, my patient that I just presented, she had neuropathy because she had nerve root involvement of the disease. So if you have a peripheral numbness tingling, you first should focus on not the peripheral nerve, the central. You should do an MRI of the spine. Make sure that the nerve roots are not encasing, the brachial plexus are not encasing with the tumor. So if you have a neuropathy in a Erdheim-Chester or histiocytic disease patient, your first is go to a mass effect rather than a peripheral effect that caused by diabetes or other diseases. And the treatment should entail the treating the underlying disease. If you have a big mass in the nerve root that impinging your sciatic nerve or on the brachial plexus, you treat by radiation and systemic treatment for the underlying mass.
Thank you so much. Any other discussant wants to ask any other question? Because I've finished all the questions from the audience. Well, in that case, there are no more questions. Dr. Jitma, thank you so much for that fantastic and wonderful presentation. It was really worth listening to you for such a rare disease and what the knowledge and the volume of knowledge you have for this disease. Thank you so much. It was quite a good learning for all of us.
Yeah, thank you everyone, and good night, sweet dreams for other part of the world. And we will start our day today after this.
Thank you so much. And
Thank
I now
you.
hand over to Zydus for the final vote of thanks. Mr. Sumit, please go ahead.
Yeah. So thank you, Dr. Jitma and Miss Grace, for sparing your valuable time. It was an excellent presentation, and I think followed by a great interactive session. And you have totally given a 360-degree view of the disease and its management. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal, for providing us this wonderful opportunity and making us a part of this esteemed academic discussion. I also thank all the discussants and participants who have joined us for this webinar. Special thanks to Dr. Amit Purana for navigating this entire webinar in a highly proficient manner. Last but not the least, this series of webinar is possible only because of continuous support from Perfect Square team. So thank you so much, everybody, and have a wonderful weekend.
Thank you. Thank you, Dr. Amit Kumar.
Thank you.
Thanks a lot. Thank you. Thank you so much.